Thanks.
Well, thanks for that introduction, Joe. It's really nice to be back and appreciate the invitation. Like many of you at the Berman Institute at the University of Colorado Center for Bioethics and Humanities, we do a lot of work at the intersection between empirical data collection and normative issues in bioethics. And I hope to weave those two together a little bit today as we talk about decolonizing global health. So I'll present two ongoing studies we have on this topic, intermesh with some of the normative bioethics. And I want to, of course, acknowledge at the outset that I'm a white male in America talking about decolonizing. And that has certain connotations to it, but I approach the topic with humility. Certainly hope, as you'll see in the course of the presentation, to elevate some scholars that some of us may not have heard of and learn from lessons in past decolonization theorizing, and hope that we can at least start a conversation. I know we got started a little bit late. I'll try to go quickly through so that there's enough time for Q&A. And maybe even before I start, I do want to express a debt of gratitude to the BI and Berman and the time I spent here, close to 9 years. Certainly mentors like Jeremy Sugarman and Gail Geller, and the work that we do is certainly informed by that, and appreciate that time. Here's just a few disclosures. As Joe sort of mentioned, I will be referencing two projects in the presentation that are funded by the Greenwald Foundation, one on mass administration of antibiotics with a co-PI, Anthony So, who's here at Johns Hopkins, and also the grant from the Fogarty International Center. A few other sources of funding listed too there for disclosure, but I have no conflicts of interest to disclose. I want to start by giving you a quick sense of just the context and the motivation for why I've been thinking about this topic and why it matters. And I'll go quickly through this part. You don't have to look far to see the history of colonialism intertwined with global health. And just to give you three examples, this is a book called Colonial Pathologies. It's about US involvement in the Philippines and the intermingling of military action and medicine in the process of colonization of the Philippines. This is Albert Schweitzer. You may have heard of the Schweitzer Fellowship, known for his work building hospitals in Gabon. But if you look closely at this slide and read some of the quotes by Schweitzer, you'll see comments like these: "The African is indeed my brother, but my junior brother." Or later on, Schweitzer writes, "I let the Africans pick all the fruit they want. You see, the good Lord has protected the trees. He made the Africans too lazy to pick them bare." But clear, obvious, mixed history within colonialism. And then moving to even a different continent, the colonial roots of Haiti's healthcare system have been well described. Many of us know late Paul Farmer's work in Haiti and all across the globe. Easy to see issues of colonialism intertwined with global health. This is reflected more recently. I love PubMed, how you can do these searches and find out what's being written. And if you do a search around the number of publications for decolonizing global health, you can see it really starting to go off the charts by the year 2022, 35 plus articles already. So this is a topic that's now getting a lot of attention in global public health. Even at the funder level, this is Roger Glass, an article written a couple years ago about decolonizing and democratizing global health as being difficult but vital goals. So a push toward recognizing these concepts even at the funding level. And then student activists, a key part of this dialogue as well. I love this Twitter account, Decolonize Global Health. If you look at the subtext, as only students could say, we're bored of the Gates Foundation telling us what to do. But those of you who may be more historically inclined probably know that this isn't the first time decolonizing has been talked about. In fact, in 1960, the United Nations, with 16 brand new members from Africa, emphasized political independence in a declaration on the granting of independence to colonial countries and peoples. And look at that first line in this snipped out text. It says, believing that the process of liberation is irresistible and irreversible. Way back in 1960. And one wonders what we might learn from similar movements in the 1960s. Continuing on till today, where this current decade is in fact the fourth The fourth international decade for the eradication of colonialism. Lots of work over decades with now attention to the political, economic, social, and cultural issues, and also a reiteration of the need for measures and reports. Reporting is always a key component at the UN, at the United Nations level, and this has been clearly recognized over now decades and decades. There are, of course, more contemporary examples of colonialism's effects in global health, and if you read the literature, these are some of the things you might see. The location of funding and funders is predominantly in old or prior colonial powers. Funding priorities favor high-income settings, interests, and goals. There's limited representation and leadership on governance bodies, minimizing lived experiences, or even the notion of language. I'll come back to that a little bit later, but the idea that there are English-dominant journals located in high-income countries as being reflective of a history of colonialism. And lists like these can go on and on. Plenty of examples about this. There are, however, sometimes more subtle examples that I think make you scratch your head about the impact of colonialism. It may seem well-intentioned to put on websites maps like these of where we work. You put pins in countries of those maps. And what do we intend by this? What does this look like to have pins and locations that we've colored around the globe, like in the lower right? How does that appear through the lens of some of the decolonizing concepts or the history of colonialism? Or even more subtle, I think, is the idea that even as we intend, laudably, to prevent duplicative efforts in global health, and we say, well, institution X works in this country, in this community, and Y works in that community, what image does it portray that that part of the world has been carved up, so to speak, in a way that looks sometimes to some observers like historical colonial practices? We're here, this is our group, you're here, that's your group. What does it portray? And despite all the attention that I mentioned earlier to decolonizing in the literature, we actually see a lot of debates already over what decolonizing really means. This is a paper that was published in 2021. It's listed as a roadmap, moving from rhetoric to reform, that is giving practical examples of what it would mean to decolonize global health practices. And you can see on the left here, an example, according to the authors, of a historical colonialist practice, meaning that staff, offices, and resources are based in high-income countries. And they argue for moving toward more equitable concentrations of resources, including staff and offices, in the geographic focus of where the work occurs, from the problem to the solution. On the other side, there are critiques like this one that actually look at roadmaps, practical actions toward reform, and so on, and emphasize that metrics, checklists, and a map, called unironically all tactics that have been and are used by colonizers. The idea that even the notion of checklists and maps and roadmaps is somehow reflective of colonial forces. Interesting disagreement in the literature around this topic. I will say that for me personally, one of the experiences I had that really made me think about decolonization was a panel at the Consortium of Universities of Global Health in 2022, where a co-panelist took an approach that actually compared and contrasted decolonization with global health equity. And I had never thought of a comparison and contrast between these two concepts because they often go together when you read the literature. And along the decolonization front, Dr. Bekele emphasized concepts of power, revolution, enemy, supremacy, racism, and sexism. And in the global health equity side, he emphasized access, harmony, partnership, diversity, and inclusivity. So clear differences in how these concepts are described in ways that I hadn't thought about. And again, that's what helped me to begin thinking about, well, what is the role of ethics and ethics concepts in decolonizing global health? How do they relate? Not saying that this is the correct way of framing these two concepts, by the way, but it just certainly made me think about it. I want to pause for a second with that context and motivation and move to one of those empirical studies. And this is the one that was funded by a bioethics supplement grant from the Fogarty International Center. Many of you will recognize the setting for this study. It's the UJMT Consortium. It's a consortium of 4 universities, UNC, Johns Hopkins, Morehouse, and Tulane. This is a training program that since 2012 had provided training to more than 200 trainees from both high-income countries and low and middle-income countries alike. Lots of training sites. I've just listed the top 5 or 6 here: Malawi, Peru, Uganda, Zambia, and so on. And at the time we did the study I'm going to tell you about, it was one of 6 such groups supporting 1-year mentored global health research fellowships. And this consortium was just refunded for another cycle. So that's the setting for our study. So what did we do? Well, we imagined and we conducted an explanatory sequential study, meaning we were going to move from some empirical quantitative data collection to then understand it a bit more through qualitative data collection and interviews. And we were focusing on the last 5 years of UJMT trainees. That's about 111 different trainees. I'll tell you a little bit about them in a second. And again, our goal was to conduct a survey to try to understand, what do trainees know and what are their attitudes toward the concept of decolonizing global health. And then we're going to move to semi-structured interviews and try to learn a little bit more about why they answered the questions the way they did. Now, there aren't validated items on decolonizing global health. So we had to create de novo survey items that we were developed from the literature, our team's experience, and we had a multinational technical advisory panel as part of the grant as well. Did 5 cognitive interviews. We iteratively refined the survey instrument so that it could be used and implemented. And then our final survey was administered online from February of 2022 till about April of 2022. And as Joe mentioned in the introduction, the broader project really seeks to develop case studies at the intersection of ethics and decolonizing global health to be used as a teaching resource. But I'm going to tell you only today about mostly the survey findings. So when we launched our survey, we got 61 responses for an adjusted response rate of around 56%. You notice that we went from 111 to 109. There were 2 people who couldn't be contacted. The email addresses weren't valid. And when we looked, we had hypothesized in advance there might be differences between high-income country trainees and low and middle-income country trainees around their knowledge and attitudes. So that's why we present our demographic characteristics in this way. Really pretty similar between the 2 groups, with one exception you'll quickly notice, which is the gender, in that trainees from low and middle income countries were far more likely to be male than female. Keep that in mind when we interpret some of the findings in just a moment. Otherwise, they're pretty similar. And then for those of you who do empirical research, one of the nice parts about doing a survey of this type is that we know the population. We have data on that entire population of trainees, so we can do a non-respondent analysis and compare respondents, those who clicked on our link and took our survey, to those who didn't. And there are really no differences in terms of gender, LMIC or HIC status, or program year, and so on. With one exception, our respondents were more likely to be postdoctoral compared to non-respondents, so more postdocs in the respondent category. This is the main finding shown graphically. There's a lot of small print, but part of this is for visual effect. What you see here are results of a 7-point Likert scale survey asking trainees to assess their attitude towards what they think the impact of colonialism has been on 8 aspects of global health. And the scale goes from -3, very negative, to +3, very positive. In each of these sections, the top row is LMIC trainees. The bottom row is HIC trainees. The brownish colored boxes are negative attitudes, and the greenish colored boxes are positive attitudes. And what you see are differences where it seems that LMIC trainees assess the impact as more positive than HIC trainees, right? More to the right, more to the green among LMIC trainees than HIC trainees. And some of these concepts you'll see here are: what has the impact been on what research questions get asked, global health funding, equal career advancement opportunities, and so on. A pretty stark finding across the board. 2 of these, despite having only 61 total respondents, are statistically significant. So a really perplexing finding to us, something that we're still trying to understand. Now, just a small note here, I did take out the neutral category. There was a gray neutral category that's in the middle of that 7-point scale. We took that out and the findings didn't change even with whether neutral is in or out. The statistically significant findings don't change. Is there a clarifying question? They were anonymous. Good question. I think I see where you're headed. And I'll talk about this because we have this opportunity by being a mixed methods sequential study. We have the opportunity to go back and ask people in interviews, why do we see this? Why are we seeing this finding? We did have a small open-ended box in the qualitative in the survey itself. We did content analysis based on the prompt, define in one sentence decolonizing global health. These are some of the answers we saw: eliminating power imbalances, local needs, local ownership, equitable opportunities, ensuring programs are culturally appropriate. Not as many obvious differences here, obviously small n qualitative, but not clear differences between the two trainee populations. Interesting to me that if we go back to those original concepts contrasting equity and decolonization, where revolution appears in the decolonizing side, as you go down this list of items, I think it looks a little less revolutionary the farther down this list that you go, from eliminating power imbalances to ensuring programs are culturally appropriate. No clear differences there. So why might this be? First, I want you to remember that gender issue I showed you. We don't have necessarily reason in advance to think that gender, we don't hypothesize that gender is a key reason why people would have different impressions toward global health. It might be, but we hadn't expected it. We had insufficient power to confirm or refute any kind of interaction with gender, right? You can imagine that with only having 61 people, we're not able to really tell if gender's the issue. But in these secondly, in these qualitative interviews, we've talked to people and said, well, what is it about this issue that could explain these differences we're seeing? Some people have said that, well, the high income trainees may have more guilt. And because they have more guilt about benefiting from colonization itself, they have more negative attitudes. There may be cultural differences or fear of retaliation that could make low and middle income individuals less comfortable expressing negative views. Or I didn't show you these data. We actually saw in our survey that LMIC trainees were far more likely to report never having heard of the concept of decolonizing global health. So it could be a reflection of just lack of awareness and lack of knowing that this is an issue. And this is in part why some people think that this decolonizing concept and rubric are unique to high-income country trainees more so than communities abroad. What do we learn from this empirical study? Obviously, there are a number of limitations. This is one program. It's a small n. These were new survey items and so on. But the what of decolonizing appeared to vary among all trainees, right? There are differences in how people defined it. And then there's this really interesting part of the attitudinal aspects of decolonizing, which I think is an understudied phenomenon, right? And this seems to vary between LMIC and HIC trainees. I think it suggests the need for more dialogue before we settle on the concept of decolonizing, especially for training programs, many of which are very eager to implement education programs. I said that was a goal of our own project. And I just want to say at the outset, we really see these findings as generating future hypotheses. I don't think this settles the issue. We don't conclude from this that LMIC trainees think that colonization wasn't so bad, right? We don't conclude that. This just opens up new hypotheses for us to think about the attitudinal and beliefs that different people have towards this now popular concept. All right, so that's one empirical study. I'm going to step back now and shift gears and talk a little bit about these philosophical roots of decolonization, asking the question, is there a philosophy to this concept? And I'm going to give two examples among many. You can go around the globe similarly and give lots of examples of scholars around the concept decolonization from the 50s, 60s, 70s, 80s. I'm just going to give you two, and we'll see what we can learn and apply there. Why go back to the roots? Well, I think one reason is to avoid this issue of co-opting the concept of decolonizing global health, making it the domain of high-income countries, of ways to mediate or mitigate the guilt of high-income country trainees. You see a quote here, we have observed a lack of reference and deference to majority world scholars, thinkers, practitioners, and activists, and so on. So a critique that the concept could be being co-opted. I think there are also important and necessary insights we can gain from going back to certain roots around decolonization. The quote here says, "For the master's tools will never dismantle the master's house." So the first example I'll give you is Fanon. Very influential figure in decolonization, a psychiatrist who was born in Martinique, a French colony. He believed in the cleansing power of violent decolonization, calling decolonization always a violent phenomenon. When Time magazine reviewed this book, they said this is not so much a book as a stone thrown against the windows of the West. Powerful quote. Not surprisingly, perhaps, being a psychiatrist, there was an emphasis on self-consciousness of the colonized mind and overcoming inferiority in his work. This was echoed in subsequent works such as Decolonizing the Mind, which emphasized that role of language in colonization, the role that English dominant or French dominant, you name it, that the language plays in colonial forces. And then just as an interesting side note, Fanon died of leukemia in 1961, actually at the NIH. So this is one of the more important figures. This book, Wretched of the Earth, is considered one of the landmark books around decolonization. I'll give you a second example, and I'll say a little bit more about Kwame Nkrumah. Was the first prime minister of Ghana, previously known as the Gold Coast, that became independent in 1957. He was educated partly in the US at Lincoln University because, and here's a quote from him, "America came to appeal to me as a Western country which stood refreshingly untainted by territorial colonialism in Africa." Many of us look at this now and think, I don't know about America being the role model, but at the time, so educated partly in the US, he recognized very early the concept of neocolonialism, wrote this book, I think 1957 perhaps. That is the idea that the social, economic, and other forces that can maintain colonialism even after political independence has occurred, whether it's financial structures, banking, commerce, and so on, could maintain some of these colonial practices, and knew this very early on. I was fascinated to learn, and you may have already known this, that Nkrumah was connected with Dr. Martin Luther King during MLK's trip to Ghana in 1957. And MLK later told Nixon, "I want you to come visit us down in Alabama. We are seeking the same kind of freedom the Gold Coast is celebrating." A really interesting connection between global movements around decolonization and the civil rights movement in the US. There was a controversial end. I won't get into the end of Nkrumah's political leadership in Ghana, but there was a controversial end to it, as has happened plenty of times throughout history. Hint, it involves the US. But Nkrumah also developed a philosophy of decolonization. It was published in this book called Conscientism. And this was seen to be really the philosophical basis, the underpinnings of decolonization in Africa. And I've been really trying to dig into this and see what we can learn. And it's been a fascinating, I have to say, read, to go back to these literature from the 60s and 70s and see what was being said around decolonization and think, well, how does it apply in the global health setting? What lessons can we learn? I'll highlight just a few themes from his work. One is that it's a practical philosophy. It's born of social currents of the time. In other words, it's a little contra Western philosophy's emphasis on idealism. Influenced by socialism, as many decolonial thinkers were, but it's very practical. It's meant to be in the world and of the world. It's a radical egalitarianism. Nkrumah wrote that each as an end in itself, based on the anthropological nature of man. And this was in contrast, in the book, it's in contrast to Kant's maxim of treating people as ends and never as a means. For Nkrumah, that's based not in rationality, as it was for Kant, not in reason. Instead, it's based on egalitarianism and what Nkrumah called materialism, which is the existence of matter and the inherent equality of matter. So it gets to the same place as Kant, but gets there in a different way. Nkrumah also emphasized synthesis of ideas, not their mere rejection. So the idea wasn't that decolonization was to forever remove potential influences. He writes that there's a harmony that will allow the combined presence of traditional Africa, Islamic Africa, and Euro-Christian Africa in tune with the original humanist principles underlying African society, enlarged by Islamic and Euro-Christian influences. So a synthesis, not merely rejection. And then really also importantly, unity, not isolationism or nationalism. Nkrumah ends the book with calling for the necessity of a union of African independent states. So again, it's not to equate decolonization with nationalism or isolationism. It's instead to see it through a new lens, and in this case, the Union of African States. So I think really interesting thoughts and concepts from the history of decolonization. Take a step the other side, and we'll look at another empirical study, this time looking at mass drug administration of azithromycin, and we'll see where we find concepts of imperialism and colonialism there. Brief background. This was a study in 2009 that basically showed that kids who were given azithromycin for trachoma control seemed to have lower mortality. Perplexing. We're giving the medication for trachoma, but mortality goes down. This was followed up with what became one of the most influential studies in this field, known as Mordor, where azithromycin was intentionally given. That's from the French, just so you know, that's from the French initials, not the American. Azithromycin was intentionally given to communities in 3 different countries. And it was again shown that in at least one of the 3 countries, giving azithromycin once a year, once every 6 months to kids lowers mortality. People don't know why, there's no known mechanism, but it lowers mortality. And this resulted in WHO recommendations on the topic. I think this was 2018, where the recommendations basically recommend against universal adoption, but recommend for targeted adoption in settings where infant mortality, child mortality is very high. Azithromycin be considered as an intervention to lower childhood mortality. This raises a number of obvious ethics issues, right? In the original Mordor study, the benefit was seen in Niger, but not Tanzania or Malawi. Only one of the settings really had significant benefit. How do you weigh the near-term risks and benefits of mortality against longer-term ones like antimicrobial resistance or obesity, changes to the gut microbiome, and so on, things that we don't understand about antibiotic use in this way? What about intergenerational justice, lives saved now versus lives saved later if antimicrobial resistance increases? Clearly lots of interesting ethics issues in this topic. And with funding from the Greenwall Foundation, we did a project that included interviews, consultation sessions, and so on key topics in this, from research ethics committee review to the on-the-ground implementation. And if you're interested in the topic more broadly, this is all published as a thematic series in the journal Infectious Diseases of Poverty, and everything's freely available. A whole set of articles on this topic. I'm only going to talk about the interviews. So we conducted interviews with key individuals regarding mass drug administration, really to understand their concepts or the way they conceptualize ethics issues around the topic. We used a trial-based purposive sampling strategy looking at 6 key MDA studies. Mordor is not the only one. There are others now, and many that are ongoing. 1-hour-long semi-structured interviews in English. With one exception, we had the unique opportunity to do a group interview with a research ethics committee from a country where MDA has occurred. And so that was done in a group setting over Zoom with a translator. And as a side note, because I like to add interesting side notes in, the first question they had was pointing out an error, a problem with our consent form. So we started with investigators for the trials. We recruited the PIs, funders, DSMB members, bioethicists, REC members, industry, and so on to get a diversity sample. And really our primary goal was to create this concept map around what are the ethics issues, how are the ethical issues being conceptualized. We conducted these from 2020 through 2022. As you can imagine, a lot of the people involved in this topic were involved in COVID response efforts. So recruitment was pretty challenging early on in this study. This is just to give you a sense that we did get a diverse range of individuals from various locales. The bottom part of this table is country, nationality, mostly US, but lots of different countries and individuals represented. As I said, our main goal was to create this concept map. I'm not going to go through this in detail. This is kind of the traditional ethics issues around risks and benefits and empowerment, equity, and so on. We created this map of how people tended to conceptualize it. But that's not the topic of this talk. I'm talking about colonialism, and this was an interesting and emergent finding that we saw within our interviews. So on the one hand, we saw people expressing a sentiment that not doing mass drug administration is colonial. This is like imperialism again. We know that this medicine given to kids prophylactically in Africa saves lives, but against the wildly low likelihood of a superbug, we don't think you should do it. Bollocks. It would be unethical not to accept some level of risk. Many people, I think, are worried about the emergence of resistance, but they have no problem going to their own pediatrician and demanding antibiotics for every little ear pain, and yet they don't want kids in Niger getting azithromycin. We heard this sentiment about other antibiotic uses in high-income countries, whether it's acne, surgical prophylaxis, irritable bowel syndrome, intestinal overgrowth, and so on. We heard this sentiment about this double standard, the way people approach antibiotics. But we also heard that doing mass drug administration could itself be perceived as colonial. Look, we'd never recommend MDA with, for instance, azithromycin, I don't know, in New York, right? It's not necessarily the risk of AMR that pushes us not to do it. Aside from the fact that child mortality is incomparable to the countries where you introduced it, the main reason is that there are alternatives in New York compared to these other settings. Or there's just been this huge tension in global health about the magic bullet compared to working together for the common good. We have a long history of being drawn to magic bullets. So the idea of azithromycin as the magic pill being given from the high-income countries into the low and middle income countries is a magic bullet to a problem that's more fundamentally social. And there was a middle ground around the idea of choice. I won't go into the whole details of this quote. I'll just highlight this last part for the sake of time. The idea of enabling them with the tools and the information and everything that they need to really, truly make well-informed, independent decisions. Earlier in this quote, there's the question, does Niger want to do MDA in Niger? So in our interviews, we heard reference to this idea of choice, perhaps hearkening back to the initial thoughts around decolonization itself, the emphasis on self-determination. But who is providing what information and how would really seem to matter if you're going to rely on choice to split the difference on this topic. So what do we learn from this empirical study? Well, I think in a practical sense, we saw that critical decision makers viewed those implications of decolonization very differently for a very concrete decision in global public health. It wasn't clear to us that all the issues I showed in that map relate to decolonizing. Is self-interest in science or funding, which we know exists in science, is that colonial? What's the difference between that and colonial influences? And again, to emphasize autonomous decision-making, that seems key. It echoes the core of decolonization, but reality is complicated. It may be laudable to say we want to empower local health ministries to make the decision best for them, but if the legacy of colonialism means that the information sources, the funding streams, the presentation are biased in some way, then this is undermining. All right, so that's the second empirical study. And now I'm just going to close with a few thoughts on bringing some conceptual clarity to this topic. Hopefully there'll be time for Q&A. I'm going to give you 5 different distinctions. One is the idea of deep versus shallow decolonizing. This is an example from the Bloomberg School here, 4 ways to decolonize global health. And this is not to be necessarily critical of shallow decolonizing, but shallow decolonizing makes real and tangible changes, such as teaching about the topic, this lecture perhaps, increasing local representation and so on, but it may pay less attention to the fundamental structures of power that underlie colonial influence. The deep end of the spectrum, I think, is well shown by Gene Richardson's book, Epidemic Illusions. Or what I mean by deep decolonizing is that it questions the colonial roots really of fundamental modes of knowing, of epistemology, the focus on epidemiology versus traditional knowledge, for example, metaphysical questions, and even ethics itself. We don't often talk about decolonizing ethics. That topic is not discussed much, but one wonders about it when it comes to deep decolonizing. Why does this distinction matter? Well, I think overly deep decolonizing thought can reduce to foundational philosophical disagreements that, while illuminating and perhaps fun to discuss, may not solve real-world problems. On the other hand, an overly shallow decolonizing risks being disingenuous or is not really about decolonization at all. Is it really about decolonization merely to talk about the topic? Right? That's what shallow decolonization looks like. Second distinction is between what I would call narrow versus broad decolonizing. This is a picture of Yosemite National Park, and you can see that in one picture, there's a peak that's here, seen in a very broad view. Here's a very narrow focus on the same peak. So we can ask, are we to focus narrowly on simply decolonizing global health itself, or more broadly on the other neocolonial forces that Nkrumah elaborated in that original book? Why does this matter? I think there are at least two key reasons. One is that there's concern that decolonizing global health in isolation could actually cause inadvertent harm, or at least unintended consequences, because yes, we've decolonized global health funding, but what about development funding more broadly? What about the rest of all the influences that Nkrumah emphasized that affect the way we do global health? How can we focus simply on global health and not these other areas? And I think adopting this broad approach means decolonizing global health as yet another reason to be intersectional and cross-sectoral. We can't leave those other areas untouched. Third, the idea of decolonizing both without and within. I haven't talked about this much, but we recall that defining global health is hard. Local is global. What counts as global health? And I think if we think about that breadth of global health, the same thing applies to the idea of decolonizing. You have to be sensitive to colonialism in all its forms, a phenomenon that's seen both within high-income countries and also within low and middle income countries. Here I'm reminded that the University of Colorado and many universities now have a land statement like this one, that the 4 campuses of our university are on traditional territories in ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. And in our COVID work, which I'm not talking about today, the idea of decolonization is influencing the partnerships we have between researchers and clinicians. The concept is coming up in the discussions we have with community around our COVID testing research. And so clearly this is a concept that may apply locally as well. Some of the same conversations we had about global health. Fourth, are we looking for a universal definition or a shared one? There have been recent calls for a universal definition of decolonizing, and I think there's value in shared understandings, but I think there's also reason to be circumspect about this idea of a single universal definition. Universalism itself can be perceived as Northern or Western, right? In the same way that Nkrumah criticized the idealism of Western philosophy. And absent addressing structural power in the first place, the definition could inadvertently reflect those same power differentials. That is, we may not be ready yet to make some kind of single or universal definition. And in fact, if we go back to some of those original scholars I mentioned, there's value seen in maintaining a dialectic in the disagreement, for not removing these influences, but simply engaging them. Fanon mentioned rational confrontation of points of view. Nkrumah, in describing his own philosophy, said that it would enable African society to digest the Western and the Islamic and the Euro-Christian and develop them in such a way that they fit the African personalities. So there can actually be value in bringing disagreements to the fore and in working through them as a dialectic. You'll see this asterisk on this slide, and that's just to remind me to tell you, I was also quite interested to see Avram Alpert's article, which emphasizes this historical and colonial roots of the dialectic itself. If you go and read Hegel and Rousseau, when the dialectic is used and described, it's often illustrated through examples to the savages, and this issue of colonialism being present even in the dialectic itself. We can really get wrapped up in knots about in this, can't we? So finally, the last question, last slide, last question, what I hinted at before, what is really the role of ethics? I think it's actually unclear how decolonizing principles relate to principles of ethics that have been developed over decades in global health. For some, and I think Bekele would say this about his original contrast between equity and decolonization, the idea of equity and partnership become means for avoiding colonial practices, or it says avoiding decolonizing, I should say avoiding colonial practices here. For others, ethics doesn't go far enough. And as I mentioned, ethics must itself be subject to decolonization, the idea that we need to move from emphases on participation to ownership, where programs are actually owned locally, or from the idea of inclusivity to real equality, or maybe inclusivity isn't necessarily needed at all. And others might see ethics and decolonizing principles as somewhat overlapping. I think it's unclear the relationship between the two. Let me conclude with just a couple thoughts, and we have little time for questions. I think this current emphasis on decolonizing global health may be reflective of frustration in the fight for global health equity. It's important, but there is reason to worry that if it's only rhetorical, it obfuscates rather than clarifies, or co-ops rather than empowers. I still think we have a lot to learn from engaging the works and philosophies of past scholars of decolonialism. Just to highlight for Nkrumah, decolonization doesn't yield egalitarianism, it's actually predicated upon it. His egalitarianism was radical and from the start, and that was necessary for decolonization, not an effect of it. As I said, that relationship to ethics is unsettled. Happy to discuss that more. And I just want to close by saying that without further reflection, this use of decolonizing rhetoric can become a judgment that ends a conversation rather than starts one. And I hope what I presented today, at least, is the start of a conversation. I want to acknowledge the people that contributed to both the empirical projects I mentioned from the Fogarty Center and from the Greenwald Foundation listed on this slide, and happy to take any questions. Thanks.
So there's one question in the chat, which is multi-parts from Rosemary Morgan. For the first study you presented, what were the participant demographics for the qualitative portion? Were you able to disaggregate data by gender to see if there were differences? Did you look for trends in the quantitative findings regarding gender differences? It would have been great to see an intersectional lens in the analysis.
The answer to the intersectional question is we tried, and we just don't have sufficient numbers in the sample to make any reliable conclusions about that. In other words, we looked, we didn't see intersection, but I don't think we can rule it out just based on the numbers that we have. The qualitative sample was done based on diversity, so we had very purposely a balanced set of genders, LMIC, HIC respondents involved. And when we did that analysis comparing LMIC to HIC, we also did it blinded. You really couldn't tell who was saying what when we did the content analysis, so that was blinded and only revealed at the end. There's a question here.
Really interesting talk. And my question is also about the first empirical study. I guess I was curious whether you were able to see in the interviews or anything, or thinking about how the fact that the low and middle income trainees are just benefiting from global health institutions and are, from the populations they come from, are disproportionately likely to have benefited from, like they have a vested interest in it in a way that it might be asymmetrical. And so that might be affecting their response and their view of these things.
It's a great thought. It's a great hypothesis for us to try to understand whether that could be driving the quote unquote more positivity. It's interesting. I didn't talk about the companion survey we did of mentors. The N of mentor respondents was low. The response rate is low. But one of the things I would say with what we have is that what's interesting is that low and middle income mentors look more like high income mentors on the survey compared to low and middle income trainees. Now, again, it's a super small N. All of this I see as hypothesis generating. I don't want to draw firm conclusions, but it's certainly something we're interested in exploring in that comparison too.
Yeah, thank you so much for the great presentation. My name is John. I'm a postdoc fellow here. I was just wondering if you could, yeah, say if you heard in any of the empirical work or in your research, sort of a conversation about reparations and how that sort of plays into your thinking about decolonizing global health and sort of the politics and struggle that might be required.
Oh, wow, great question. No, we did not hear that. We didn't ask it in the interviews either. It's a great question. I mean, one could see how that could be one of the techniques among strategies among many that could help support decolonizing efforts. It wasn't something that came up. You know, for us, this isn't a training program that's funded by Fogarty. And so a lot of the funding quotes were really around funding inequity. You know, that most of the funds are in high income settings cost more. There should be more attention given to local funding and equity, equality in that regard, but not specific to, that's different than, I understand, that's different than reparations. Great question.
Great talk. Thanks, Matt. We miss you so much. So I don't know if this is kosher, but I am really interested in your azithromycin commentary. And I don't know if it's fair to ask Alzheimer. I would love to hear whether these discussions took place in the whole vitamin A work that you did.
Yeah. Yeah, the risk is different.
And in every place you. Only one of the three. Actually, I was very much involved with the Mordo study because it means that they were actually done.
I was sweating during that portion of the talk.
I mean, it's really interesting because the original study, the observational study, that study was analyzed. All children were offered the mortality of the compliers and the non-compliers.
Mm-hmm.
Test would be lower. It's going, you know, through that. There's a discussion meeting that had lots of people in the room.
Mm-hmm.
So I didn't have, I couldn't say. The fund study, fund research. I can believe. Only one out of the three, and then it became a big argument about what do you conclude, because if you put them together, you have no results. It turns out that the one place where it was a positive actually had the highest.
Mm-hmm. Mm-hmm.
We're going to have any impact on that. Follow the policy implications. Hopefully, where they're recommending using it, if at all, is in places that they have. Certainly makes Trump go well.
Yeah, interesting. Okay.
Vitamin A and
Well, vitamin A is very cheap. Zithromax is not cheap, except that Pfizer made it free.
Yeah, there are questions about what it would mean to roll it out into full implementation and what that would. Mm-hmm.
is us and sort of funds this all in the context of
Oh, yeah, not in the interviews. The people we spoke to, didn't necessarily make that connection. It seemed like, I guess I would say my impression from the interviews is it seemed like everyone knew that it was donated and people weren't really talking about what it would mean for widespread implementation and the cost implications of that. It was almost like that's a conversation we're going to have later.
Um,
Sorry, do you mind using?
Yeah, no. How would you interpret the fact that there was a WHO recommendation? Do you see the same colonial impact at WHO and it's just going on down the line? Or do you feel that that's, less colonial because of representation purposefully amongst the larger number of countries?
Yeah, ideally it is. And I guess I would say that there was a ambivalence in some ways about the WHO. On the one hand, they were seen as heavy-handed and potentially not fully representative, right? On the other hand, many people saw that they had such an important role to play in making a recommendation. And if you look at those recommendations, the third bullet point was that MDA of azithro should only be recommended at places where other strategies like sanitation, hygiene, and so on are strengthened, not present to some sufficient degree, but strengthened. And people really, the people we talked to spoke about how important it is for WHO to make the guidelines, because then, ministries and so on have something to rely upon when they make their decisions. But there was a bit of still concern about whether, and that was reflective in that quote about let Niger choose for Niger, was the perception that there could be too much authority and decision-making in the hands of WHO. Yeah.